And thanks for the invitation to be here. So, first, the obligatory disclosures. Okay, so the objectives of this talk are to understand the mechanisms and mechanics of performing whole genome sequencing surveillance in a hospital, how this approach leads to improvements in patient safety, and also the economic benefits of genomic surveillance in healthcare. Okay, so basically, I'm going to give a brief introduction, and then I'm going to talk about the results of our system that we call EDSHAT. First, I'll talk about a 2-year phase in which we did traditional infection prevention practice, as we normally do, and then running this new system in the background so we could compare the methods and the results after 2 years. And then phase 2, where we converted rapidly to real-time genomic surveillance in our hospital. I'll talk about other EDSHAT applications that we're now looking at. I'll talk briefly about barriers to implementation of this approach, and then I will summarize. So first, introduction. So I'm preaching to the converted here. Basically, you know the enormous impact of HAIs, huge number of infections, 100,000 deaths, enormous cost for our health systems, and somewhere on the order of 7 to 10% of patients will develop an HAI during their hospital stay. So the tipping point for us at the University of Pittsburgh was this outbreak that occurred in 2012. It was caused by Klebsiella pneumoniae. We had 17 cases over 14 months, and the transmission route was ERCP scopes. This was a really very impactful outbreak, 12 bloodstream infections, 5 deaths. And when we did reactive sequencing, we identified contaminated scopes as the transmission route. And this took over a year to detect. So we said, basically, why are we still doing it this way? This is crazy. KP infections are common in our hospital, so it was very difficult to detect these relatively small number of cases over a 1-year period. And we figured that if we had detected this outbreak early, we could have prevented 14 of the cases, 9 of the bacteremias, and 3 deaths, and we could have saved a lot of money. Just the bacteremia alone, we could have saved over $150,000. This wasn't just us. This was a national outbreak. This was due to contaminated endoscopes. Olympus is under criminal investigation for this series of outbreaks. Okay, so one of my favorite quotes is that the current methods that we use for outbreak detection in hospitals is based on methods that are over 150 years old. And that is actually correct. And then another quote, this method of looking for temporal clustering in hospitals misidentifies transmission where it has not occurred and misses transmission when it has. And I'm going to show you evidence that both of these quotes are very relevant. So basically, the translation is we are guessing, not detecting when it comes to outbreaks in hospitals. Okay, so definitions for how we use sequencing. So the traditional approach, so for many, many years, my lab has done first PFGE and now sequencing in reaction to suspected outbreaks. And then the idea is to either confirm or refute the outbreak. And the purpose is to investigate outbreaks, but a very different approach is to use genomic surveillance, which is sequencing all isolates, whether you suspect an outbreak or not. And this is for outbreak detection. And I'm going to try and convince you that this is a far superior approach to dealing with outbreaks in hospitals. So what are the methods we use now? We monitor certain pathogen. We keep line lists of infections. Typically, it requires astute healthcare workers noticing something unusual bug, or a clustering of infections on a unit. And then my lab and other labs will do sequencing. And again, this approach misses many, many outbreaks, delays recognition of others, and falsely identifies outbreaks that are not confirmed. So really the intellectual framework for this approach for genomic surveillance in hospitals comes from a study that was done by the Minnesota Health really 30 years ago now. And what they did was, so E. coli and 157H7 is reportable in all states, and typically labs, or I'm sorry, state health departments would count cases shown here, and then they would rely on somebody recognizing an outbreak and reporting it to them. And they said, well, why don't we try something different? Why don't we actually perform PFGE on all isolates and see if we can identify unrecognized outbreaks? So that's what they did. They basically took all of these cases. So this is, January, individual cases, not many. And then when Minnesota finally thaws out in the summer, people start flipping burgers on the grill, and you get a ton of E. coli cases. And so they did PFGE, very crude method, but very powerful and useful during its heyday. What they said was, we're going to color code these cases. If they match by PFGE, then we're going to color code them as matches on this epi curve. This is the same numbers, and all of a sudden the outbreaks basically come to life. You can see no outbreaks here. Here's an outbreak in May in red. See this bluish one here, this sort of biliary green one here. And the bottom line was they uncovered otherwise undetected outbreaks. And this actually now is the basis of CDC's PulseNet, which has been in effect for over 20 years. When you hear about a multi-state outbreak of Listeria or E. coli or Salmonella, it's usually PulseNet that picks it up. The states sequence all of their isolates of, say, E. coli, upload to the PulseNet website, and then PulseNet is able to look and say, there's only one case in Nebraska, but 2 in Minnesota. And so that basically is able to identify these national outbreaks of foodborne diseases. Truly has revolutionized the detection of outbreaks of foodborne diseases. So that's sort of the intellectual framework or basis for the project we initiated at the University of Pittsburgh. So how does EDSAT work? It's basically 2 major components. Whole genome sequencing is performed on all isolates, say, for example, all Pseudomonas isolates. If you've been in the hospital for 3 days or more, and you have Pseudomonas isolated from any site, any unit in the hospital, we sequence it. So whole genome sequencing surveillance. And the beauty of this is it detects outbreaks of 2 cases because you're doing it, presumably, the idea is to do it in real time. But doing the sequencing doesn't tell you the cause of the outbreak. So the second component is machine learning of the electronic health record, which identifies the transmission route. So basically, this is a project we did with Carnegie Mellon University, but it's basically a case control study on steroids. We basically tell the algorithm, machine learning algorithm, these are the outbreak cases. Here's the rest of the patient population. It does a massive case control study and gives us the most likely transmission routes, which we can then investigate and confirm. So just before I get into some of the results, I just want to, for those of you who don't do this for a living, we do sequencing, and we have these things we call SNPs, single nucleotide polymorphisms, and basically just sort of genomic sequencing 101. Most bacterial genomes consist of 2 to 7 million nucleotides, depending on the species. And as these bacteria replicate, they make mistakes. So if you focus, I think it's the guanine here, this bacterium, say, is replicating, and the guanine becomes an adenine, and that is a SNP. And we can use the number of SNPs between bacterial isolates to determine genetic relatedness. Now, in general, when we started this, we said if you had 15 or fewer SNPs between bacterial isolates, that was evidence of an outbreak. We've refined that, and I'll show you that in a moment, but that was our starting point. And just to give you a sense, a bacterial species, if they're unrelated bacteria within that species, you can have tens of thousands of SNPs. That's why 15 SNPs or fewer is considered to be highly related. So how does EDSAT work? So if you go to our hospital and you ask patients what EDSAT is, they have no idea what you're talking about. If you ask the healthcare providers, they have no idea either. This runs in the background. We do nothing to the patients. We don't contact the physicians. We just basically go with existing data and isolate. So patients are in the hospital. They have EHR data. A gold mine for this effort is charge codes because hospitals want to get paid if they put a Band-Aid on you. So they charge you for everything. And so any diagnostic procedure, almost everything that's done to you in the hospital is in a charge code. And then we go down and we collect routine clinical specimens. We have a huge list of EDSAT organisms. If you're in the hospital for 3 days or more, we go and we sequence. We do whole genome sequencing, and then we identify the outbreaks by the sequencing and the responsible exposures or transmission route by the machine learning. We identify the transmission route. And then a key part of this is very close collaboration with our infection prevention and control team, because they're the ones that then will interrupt transmission. So first, as I mentioned, we ran EDSAT retrospectively. So we would sequence not in real time, but every 6 months. And that would allow all the outbreaks to play out while we were basically doing reactive sequencing per our infection prevention requests. This was basically proof of concept. Does this work or not? So let's go to that phase. We published this a few years ago. So basically during the 2-year period, we sequenced 3,100 isolates, and each dot is an isolate sequenced. And so the inner circle, well, the outer circle is all of the non-clustered isolates. And then the inner circle are those that clustered. So for example, if you look at C. diff here, a lot of unclustered isolates, but you can see that we found clusters here as well, and same for all the other species. So speaking for a friend, of course, sometimes when you write an NIH grant, you bluff. And one of the things we said when we wrote our first NIH grant in 2016 was that we're going to identify novel transmission routes by doing this. So we started sequencing in November of 2016, and immediately an outbreak popped up. And so this is a heat map showing a bunch of patients in a VRE cluster. So this is VRE. And you can see through this heat map, these are based on the small number of SNPs, these are highly related isolates of VRE. And that's a red flag that we've got an outbreak. And when we looked at the SNP distribution between what we thought were outbreak strains and other VRE isolates in the hospital, clearly they were clustering together. So this is before the machine learning was up and running. So we looked in the EHR the old-fashioned way. And basically of the 10 patients in this outbreak, 9 had had interventional radiology procedures done. And so this is the gurney where patients lie for their procedure. I think you can see here there's this massive syringe where sterile contrast is drawn up to be injected into patients. So I'm going to show you how this is done. So here again is this giant syringe. And this is a sterile tube that is used to basically suck up the sterile contrast. And then this shows the technician basically, after having put the straw on the syringe, sucking up the sterile contrast into the syringe. You don't need to be an infection preventionist to know what's wrong with this picture. Anybody want to throw out some ideas here? Yeah, so first of all, there's no hand washing. That's not shown here, and she's touching a sterile it looks like a juice box straw with her bare hands. And this was not photos from us. This is a global manufacturer of this equipment, a training video on their website. So we said, where did you learn to do this? And they said, oh, from this video. So anyway, this outbreak was undetected by traditional methods. And why? Well, this was a novel transmission route. This is, in fact, has not been described in the literature before. We don't know when it started, but the reason why it wasn't detected, the patients were on 8 different nursing units. So the traditional approach of geotemporal clustering doesn't work for something like this. And you would never detect this outbreak. So we asked them to show what they were doing. We saw that, and we said, stop, throw that contrast away. And there's a patient on the gurney. and taught them, good IP practice, and the outbreak totally stopped. So this was one of the most notable outbreaks during this 2-year retrospective period. Also, Pseudomonas associated with gastroscopy. We have an embedded chronic care facility, and multiple outbreaks of multiple pathogens at that facility. Outbreaks in ICUs, C. diff outbreaks associated with wound care. We had a number of different small clusters of C. diff, all linked to wound care. If you've ever observed how wound care teams work, it's not difficult to understand how you could transmit C. diff. And then MRSA infections associated with EEG. So that was what EDSAT showed during this 2-year period. What did traditional IP practice show? So during that same time period, we got 15 requests for reactive sequencing involving 133 patients. Only 5 patients were from 2 clusters were actually genetically related. So most of these suspected outbreaks were just false alarms. So reactive sequencing, most outbreaks identified by EDSAT and created multiple false alarms. What about economic impact? So in terms of clinical impact, we estimated that EDSAT could have prevented 25 to 63 infections if run in real time, and it would save money. So it doesn't make much sense that it would save money, but if you think about it, a single Pseudomonas pneumonia costs about $25,000 to treat. That's a huge proportion of our sequencing budget. You don't have to prevent a lot of infections actually to save money. And so when we did all sorts of sensitivity analyses, EDSAT was cost savings the vast majority of the time. Okay, so once we had these findings, we immediately moved to real-time surveillance. We didn't think we could do this, with a lag time anymore. So I'm going to show you those results. So this shows similar results. This figure's slightly changed, but same basic concept. So we sequenced about 4,000 isolates. 12% of isolates were related. So think about it. We sequenced a large number of isolates, and we detected a bunch of clusters. Clusters range from 2 to 16 patients. Median turnaround time was about 2 weeks. And we identified the transmission route in about 61% of cases. So again, this is all Pseudomonas here, unrelated cases here, and then our clusters up here. Same for VRE, for example. So what are the notable outbreaks? So first of all, we had 9 endoscope clusters. To me, this is actually the most substantial finding of this real-time analysis. All of these endoscope clusters stopped at 2 patients. We identified the outbreaks, we transmitted that to our infection prevention team, and they stopped the outbreaks at just 2 cases. And I showed you that devastating KP outbreak that we had that led to the institution of this project. And so we thought this was a really significant finding. 3 clusters with shared ventilators. So 2 clusters, same ventilator, same ICU, but we identified an outbreak of same ventilator in 2 ICUs because the ventilator was moved from one ICU to the other. And without the sequencing, we never would have identified that this ventilator was the culprit. 3 patients with Pseudomonas infection, same ICU bed. Cluster of VRE infections from wound care across multiple nursing units, and no additional IR outbreaks because of the intervention that we had done a few years earlier. Incidental findings. So we identified a number of outbreaks from outside facilities. So a patient develops a fever at a nursing home and they get sent to the hospital with, say, group E strep bacteremia. Another patient with fever comes from that same nursing home. We do the sequencing and we identify the outbreak that the nursing home was unaware of. And then also, probably remember the artificial tears outbreak, devastating Pseudomonas outbreak, deaths and loss of eyes. And we had 2 patients. We couldn't figure out what the transmission route was because the sequencing, it was like 1 or 2 SNP differences. And then we uploaded our sequences. We downloaded the sequences from the outbreak from CDC and found that these patients were part of that outbreak. So in terms of trying to figure out the clinical and economic impact, we had to use modeling because now we were intervening. So we compared our real-time period to our 2-year retrospective period that I showed you earlier, where we had no interventions except for the IR outbreak, because that was the one that we detected while it was still ongoing. Our analysis was transmission route specific. So, for example, if a particular strain was causing an endoscope outbreak and we intervened there, that's how we analyzed the data. If that strain also got into the patient population, it was transmitted onto a unit. If we hadn't intervened yet, that was not counted in the analysis. And we compared the size of outbreaks within the same route during the retrospective period to the real-time period. And then we did a bunch of sensitivity analyses as well. So what was our finding? So we estimated that we prevented 62 infections during the time period with a range of 22 to 126. Net cost savings very similar to the retrospective period, about $700,000 with a range of anywhere from 26,000 to 1.8 million. And importantly, and if you're going to be talking to hospital administration, is to say you get a 3.2-fold return on investment. And this impact was shown after several years of EDSAT running at our hospital. So we'd already reinforced a lot of our infection prevention methods. So we think this is a conservative estimate if we were starting out anew. So I mentioned SNP cutoff. So we initially started with 15, although we soon learned that for C. diff, 15 is way too many. We'll talk about that in a moment. So what we did was we took all of our pairwise isolate comparisons and said, by number of SNPs, what was the likelihood of finding a transmission route? So for example, if 2 isolates had 0 to 1 SNPs, shown down here, there was about an 80% chance we would find the transmission route. And as the number of SNPs goes down, then the likelihood of finding the transmission route goes way, way down as well. So we ended up concluding that even though we identified transmission routes, between 10 and 15 SNPs, the most efficient way of running the system would be to look to sort of consider an outbreak when we had 10 or fewer SNPs. Okay, so what about other EDSAT applications? I became fairly convinced this was the way to go, just based on the improvements in patient safety. But what else could we be doing in terms of expanding this approach? So number one, we have explored the incorporation of respiratory viruses. So we know there's transmission of SARS-CoV-2, flu, RSV in hospitals. We probably all have had patients been in the hospital for 2 months, and they have an RVP now positive for flu. That was acquired in the hospital. So the other thing is, and I'll show you some data from our initial analyses of respiratory viruses. We didn't initially include non-tuberculous mycobacteria, but we decided to do a 1-year pilot of retrospectively sequencing all of our NTMs. It's about 120 or so in our hospital per year. This was an eye-opener. We have identified transmission. We had no idea what was going on. And this has led to a series of extensive investigations to identify what's going on. And some of these infections, M. abscessus, for example, can be devastating. And so we are working really hard to figure these outbreaks out. We're also doing some limited environmental surveillance cultures, for example, for Pseudomonas and non-tuberculous mycobacteria. We also have a sort of a side project where we're not only looking at, EDSAT looks at bacterial transmission, but there are plasmids that can be transmitted between or transferred between multiple species. And so we've had outbreaks where we have an outbreak of a particular plasmid, an NDR plasmid, but in like up to 7 or 8 bacterial species, typically gram-negative rods. And so we have a project to use Illumina sequencing, which is not traditionally used for elucidation of plasmids, for tracking plasmids in the hospital. And then we also really want to start talking about, I mean, most of the evidence for genomic surveillance comes from teaching hospitals. But I'm guessing, you know, a lot of community hospitals have less complex patient populations, but they have less sophisticated IP teams as well, or IP programs. And so we really want to start expanding to non-teaching hospitals. UPMC, we have 40 hospitals from the tertiary care all the way to small community hospitals. So we're starting to talk about expanding to other hospitals. Vigia was a project we started in Brazil to look at sort of LMICs in terms of what do we find in terms of using genomic surveillance. This got put on hold by recent developments in Washington, but we are still hoping to pursue this project. I think it would be quite an eye-opener for LMICs. We're also looking at an approach called EDSAT Lite, where we're saying, you know, can you give up sequencing or sequence a lot less? So using routine available microdata like AR data, multi-TOF data, which has been sometimes used to grossly cluster isolates. So those kinds of data, and then EHR data, can we identify outbreaks that way? We're working out it. I'm not overly optimistic, but that's still a work in progress. And then we found, you tend to think of sequencing as the most discriminatory method for identifying relatedness in bacteria. And for C. diff, it's not. Years ago, we developed a method called MLVA, highly discriminatory for C. diff. So we said, well, what if we were to do in silico MLVA? Would that improve? So if you have a cluster of, you know, that's 0 to 1 SNPs, we can't find the transmission route. Could we blow those clusters apart by using in silico MLVA? Okay, so first, respiratory virus. So this, we had a collection in our lab, in our micro lab, 2018, 2020, before the pandemic, of RVPs that were positive for a number of different viruses. So we said, what if we, you know, were to sequence those? Would we find any clusters? So here is rhinovirus, and you can see we identified a cluster of 5 patients here, and then a bunch of twosies. Human metapneumovirus, a few clusters of twosies as well. RSV, a cluster of 4, cluster of 3, cluster of 2. And then flu, we also identified transmission. And so it's clear that we can identify otherwise unrecognized outbreaks using genomic surveillance. But we're now doing a 2-year prospective real-time analysis to see what the utility actually is. I mean, it's not, you don't have device-related infections generally, so we're not sure what the impact is going to be, but we're clearly going to be looking at this really, really hard to see whether we want to incorporate respiratory viruses into EDSAT routinely. So I mentioned MLVA. So this is multi-locus variable number tandem repeat analysis. Again, it was a method that was developed for C. diff by us and others during that transition between PFGE and sequencing, and found it to be quite useful. So we took C. diff isolates that had no SNP differences. So for Pseudomonas, if you have 0 SNPs, you can easily identify the transmission route. But for C. diff, we had outbreaks we could not do that. But if we did MLVA, there's something called STRD, which is basically the sum tandem repeat difference between 2 isolates. And so 0 SNPs, we found a range of STRDs of 0 to 6. 1 SNPs also blew them apart, and then 2 SNPs as well. And we found that if we were able to identify a unit epi-link for isolates that had an STRD of 0 to 3. So the bottom line is here, you can use in silico MLVA to blow apart clusters of of 0 to 1 SNPs of C. diff. And so, for example, now if we have an outbreak that has 0 SNPs, but the STDRD is, say, 7, we know we're not going to find a transmission route. They're not that closely related. So that is something else that we are now incorporating into our algorithm. So bottom line, MLVA provides more discriminatory power than SNPs alone. So I'm going to make a prediction. I'm going to say that eventually, I don't know if it's 5 years, 10 years, but genomic surveillance will eventually become a routine part of US healthcare, because our current approaches to identifying outbreaks just are not adequate, and genomic surveillance adds a lot. Okay, so this is great, but how do we get this started at our hospital? These are questions we often get. And so we wrote with some very esteemed colleagues in genomic epidemiology globally, an opinion piece not that long ago to sort of discuss what the barriers are and how we can overcome these barriers. So what we've really been focused on at our institution has been evidence. You can't just say, this is great, do it. You have to really provide evidence that it improves patient safety and also potentially could save money. So there's the financial part, and there's two parts to that. So hospitals get, really like reduced length of stay. HAI, some of these transmitted infections can increase hospital stay by, 8 days, 2 weeks. And so that's one sort of, touch point when discussing with hospitals. And then you have the payers. They pay a huge amount for these infections. So there's all the financial aspects and trying to push the right levers to make this happen. So infrastructure. So I have a research lab, so we can do it, but most hospitals do not. And so you need commercialization of these approaches, commercialization of real-time sequencing, and also these algorithms to identify the transmission route. And there's all sorts of other, regulatory and other issues. So I mentioned the evidence, and I really think there needs to be a lot more done in this regard in terms of not only teaching hospitals, but also sort of mid-level hospitals, as well as community hospitals, to get a sense for, how widespread should this be? Should it be just in teaching hospitals? My sense is probably not, but that research has to be done. And I mentioned the financial part, and so we are working really hard to understand what the levers are. As I mentioned, length of stay, and hospitals get dinged if they have a high HAI rate. The CMS will ding them financially. And so there are all these different levers you can push to say, not only is this good for patient safety, but it also is good for the bottom line. And then again, I mentioned infrastructure. There are a number of companies working on providing real-time sequencing services. And really, it's important. These folks recognize the need to come in at a low cost point in order to make hospitals incentivized to do genomic surveillance. And then there's all sorts of issues with methods. There's no consensus on the optimal sequencing platform. Most people are using Illumina, but there are other platforms as well. And how do you, the real sort of secret sauce is how you analyze the sequence data and how do you interpret the sequence data. And so you need, really good bioinformatics pipelines. We have developed using publicly available tools and automated pipelines. So every week when we get our sequencing results back, we go into this automated pipeline, and very quickly we get the clusters for that week. And we typically have at least 2 or 3 new clusters every week, but you have to have a commercial product that will do this for hospitals. Yeah, and there's all sorts of issues, regulatory issues. You need to be CLIA certified to do sequencing. CLIA certification typically is for things that are going into the chart. We don't put any of our results into the charts. There's this discussion about CLIO certification. There's all sorts of legal and ethical issues about patient notification. And so, everything is simple until you think about it. This is very doable, but it is somewhat complex. Okay, so we're going to continue to generate evidence. We're working with a number of different professional societies. I'm giving a talk at ASM Microbe next month. And then we're also now, our NIH grant, it's in a 5-year renewal, but it ends next year. And, this was novel when we started. It's not novel anymore. So we're probably not going to, we may not get additional funding. So now we have to go to our hospital administration and say, do you really want to go back to not doing this, given the improvements in patient safety and the potential for saving money? But it's a complex discussion, particularly in the setting of COVID, where hospitals that were had thin margins to begin with are now actually losing a lot of money. So these are difficult discussions. So to summarize, genomic surveillance prevents infections, saves money, clearly superior to traditional methods, and it goes way beyond geotemporal clustering. You see some of the publications that are out there that are using sequencing of everything. They still focus on geotemporal clustering. And the key message, I think, is you've got to look for exposures that are not on the nursing unit, because those are often the most meaningful outbreaks. And I've now come to think of this as a sort of a real-time quality improvement tool. So we identify a couple clusters every week. We identify the transmission route. And so our IP team is constantly going and improving practice throughout the hospital. So it's a real-time QI tool. And a nationwide system, a true PulseNet, would really have benefits in addition to those seen in individual hospitals. For example, that eye drop outbreak would have been detected much sooner if hospitals were doing real-time genomic surveillance. But there are, as I pointed out, barriers to widespread implementation. So great people working on this project. So these are the folks from my genomic epi lab, tremendous collaborator. So Graham Snyder, many of you know him in this room, a phenomenal collaborator, because it's Graham and his team that basically has the impact on the ground in stopping these outbreaks. Our collaborators at CMU with the machine learning and economic analyses, and many of you know Von Cooper. He's now the president, or about to become president of ASM. Daria Van Tine, also a phenomenal collaborator. Then we've got truly our boots on the ground and our infection prevention team. Again, Graham, Ashley Ayers, and then a bunch of really, really fabulous infection preventionists. And then funding for our reactive sequencing has always come from our hospital, and then NIH has supported the research over the past 10 years or so. So thank you. I'll stop and see if there are any questions.
Thanks for a great talk, super interesting. One of my questions, and one of the questions we've had from our IT team is the sequencing information we are in theory going to have. The other side of it is putting together the epidemiologic side of it. I mean, you didn't talk as much about the machine learning part of it. That's where I think there's concern in our part about how do we identify the source of the outbreak without some maybe assistive tools, and maybe have thoughts on how to do that more efficiently? Because I know that's when we talked with our IP, that's our concern, is we'll identify these related cases, and where do we even start digging?
Yeah, we're working on a paper on that right now. So what does the machine learning add? So what we did a comparison between machine learning and basically a IP reviewing, and a very, very experienced IP reviewing the EHR manually, the old-fashioned way. What we showed is that machine learning is much quicker. But if you have an experienced IP, the machine learning does not detect a lot of additional transmission routes. It does a little bit, but it's so the bottom line is an experienced IP going to the EHR, knowing where to look. I mean, knowing which nook and cranny to go into, but not just looking geotemporally, but looking at procedures. It can be done without that. But again, there are companies that are working on commercially, making tools commercially available that will do what we do, in an automated fashion. Does that answer your?
Time that's from scratch. The machine learning, I assume, saves time.
It does save that's the other advantage. So if we were to go, say, to expand to 5 other UPMC hospitals or 10 or 20, then it's overwhelming to, every week to get, dozens of clusters. That's where the machine learning, it does save time, and it really would be crucial. But again, a single hospital with an experienced IP will spend more time than machine learning will, assisted machine learning will do, but it still can be done. Okay, great. Thank you very much.